All right, everyone. So this week we will be talking about looking at the criteria or what we may see in our office or in our agency with somebody who may be presenting with schizophrenia or some other thought disorder that would be a differential diagnosis for schizophrenia. So some features that really distinguish schizophrenia from any other type of thought disorder or other mood disorders that we'll talk about next week. So there are 5 areas. Delusions, which are large patterns of thinking that, I'll go into them in the next couple of slides, but these are large kind of belief systems that are potentially not, that are not rooted. They're not potentially not rooted. They are not rooted in reality. Hallucinations, these are sensory experiences that are not rooted in reality. So thinking about your 5 senses, the most common hallucinations are auditory and visual, but there are olfactory, touch, and hearing that's auditory. What's the other one? So there's sight, smell, taste, touch. So taste is one of the lesser common ones as well. Disorganized thinking or speech. So sometimes a little like pretty difficult to follow in a conversation where the person you may experience them as kind of tangential or all over the place. Grossly disorganized or abnormal motor behavior. And we'll talk about the different aspects of catatonia. So we generally tend to think of catatonia with the negative symptoms, but there are some positive symptoms with that, or active symptoms. And then some negative symptoms of schizophrenia. I think generally when we kind of think about schizophrenia, we think about these things that are present, that are kind of active, maybe a little bit chaotic, but there are absolutely negative symptoms with schizophrenia as well. So looking specifically at delusion. So these are fixed beliefs that are not amenable to change, even when you present the individual with evidence of its contrary. So I wanted to share with you several of the types of delusions that an individual may be experiencing. Generally, one type of the delusion is prominent. It's not impossible that an individual can have different types of delusions. They just tend to have one kind of delusion that is most present. So the most common type of delusion is persecutory in nature. So this is the belief that this individual has people conspiring against them. Maybe they're being cheated on, they're being spied on, they're being followed. They may be very hesitant to eat any sort of food that doesn't come like very clearly sealed. There's individuals with persecutory delusions that like will only eat canned food, or they are convinced that canned food, all of their canned food is poison. So just know that one of the difficulties of schizophrenia and associated thought disorders is that they're just incredibly diverse in their presentation. So other things, they're being maliciously maligned, harassed, and these are usually when they are feeling as though they're being like some kind of obstacle is put in the way. It's usually some more like long-term, larger vision goal of theirs. So they may be resentful or angry, and some can resort to violence. But one of the things just to keep in mind, and I think I'll say this in a later slide too, is individuals with schizophrenia and schizophrenia like diagnoses, they tend to have much more violence perpetrated against them than they ever perpetrate against anyone else. So just thinking about, some of these larger systems at work here, we know that mental health is stigmatized. I would argue that schizophrenia is probably the most stigmatized diagnosis that we have. So this is potentially a diagnosis that people are not very vocal about for fear of their safety. So just remember that the incidences of any sort of violence that is perpetrated by an individual with schizophrenia doesn't even touch the violence perpetrated against them. So referential type. So this is a belief that, there's these environmental cues that are directed at this person. So, lights, sounds. This could also be where, and this is usually on a more like micro level where, an individual on the street maybe smiles at this individual, and this individual thinks that this is like a nod to something that is very specific to them. A jealous type. So the central theme is this individual's delusion toward, I'm sorry that this is his or her, I should say, their spouse or partner, that they're being unfaithful. And quite frankly, any evidence to the contrary is just more evidence for the individual, if that makes sense. So if you're like showing me your text messages, or you are showing me where you've been, that's just you even more fervently trying to cover up the fact that you actually were cheating. So this is where some of that, these fixed beliefs that are not amenable to any sort of evidence to the contrary. Grandiose delusion. So this is when an individual believes that they are exceptional in some area where maybe they are not. Abilities, wealth, fame, notoriety, something like that. Erotomanic is when the individual believes that another person is in love with them. And this is usually maybe somebody of, quote, like higher stature, higher visibility. So it might be, a celebrity or something like that, but it can be like a complete stranger. It just tends to be somebody who is known. Nihilistic, which means that the person believes that there's a major catastrophe that's going to be occurring. And then the final type is somatic. So this is preoccupations regarding health and organ function. So this is thinking like ones that I've come into contact with are like an infestation inside the individual's body, whether that is creatures crawling just underneath the skin, that there are bugs or worms inside of their like digestive tract. And so you can see here, just the person emits a foul odor. They have potentially, I mean, I don't know if this would necessarily fit criteria for like body dysmorphia or anything like that, but where the body is misshapen or ugly, they believe that parts of their body are not functioning appropriately. So, these are physical beliefs on their physical functioning, whether that is limbs or organs. So Dr. Francis, I really appreciate what he says about the categorization of bizarre and non-bizarre delusions, because it really is subjective. So the general definition of a bizarre delusion is clearly implausible and not understandable by individuals who are within the culture. So it would kind of like, make sense to those individuals, and they are not derived from ordinary life experiences. But listen to all of these valued terms. So clearly implausible, according to who? Not understandable, according to who? Don't derive from ordinary life experiences, according to who? So you can kind of see how these categories of bizarre and non-bizarre may not be very helpful, and may perpetuate some kind of stigma or stereotype or something like that. So just be aware when you're in conversation about this, of like being very critical of the assessment that we make around bizarre and non-bizarre. So delusions express a loss of control over your mind or body. They are generally considered to be bizarre. So these include thoughts of having been removed by an outside force. So, it says here that alien thoughts are being put into your head. It could be that you were removed from another planet, another solar system, and placed here on Earth. That you have no control over your bodily function. So your body's being acted upon or manipulated by some kind of outside force. So again, I guess it doesn't really, like, delusions are delusions, whether they're bizarre or non-bizarre, but these are just sometimes some common ones in regard to the somatic type. So the difference between, and I think this is very important, particularly given some of the political landscape. But, sometimes people have very strongly held beliefs that we very much disagree with, or we really don't see the plausibility. And this is an important distinction, because the difference between a delusion and a strongly held idea can sometimes be difficult to decipher, but it depends in part on the degree of conviction in which the belief is held, despite clear or reasonable contradictory evidence regarding its veracity. It also can be is this strongly held idea held by a group of people? So sometimes a way to distinguish between a delusion and a strongly held belief is if that person is kind of in isolation, believing this. So, we could get into things like cult delusions and stuff like that, but that's one of the ways to distinguish between it. So to screen for a delusional disorder, one of the first questions that you can ask is, do people ever say that you have really strange ideas? Just to get, again, these, when you're doing assessment, some of these more pointed, direct questions that can help you in deciphering which diagnosis is appropriate. So it's to kind of start you down that delusional disorder decision tree. So the second feature of psychotic disorders is hallucinations. So these are perception-like experiences that occur without any sort of external stimulus. So again, these are all 5 senses, but the most common are auditory and visual. So they're vivid and clear with the full force and impact of normal perceptions, and they are not under voluntary control. So these are things that, I don't know, maybe let's say, I don't know if any of you have been so tired that you see something, or, it's late at night and you watched a scary movie and you swear you heard something. So with the experience that you had in thinking oh my gosh, that definitely happened, that's akin to a hallucination where you didn't manufacture that. It was very kind of spontaneous. So they can occur in any sensory modality. Like I said, auditory hallucinations are the most common. And then that's followed by visual. So auditory hallucinations are usually experienced as voices, but the individual is able to distinguish that from their own kind of internal dialogue. So it's generally not in the individual's personal voice or internal voice, but the person can identify that these are different than when they are just kind of thinking to themselves or talking to themselves. So hallucinations need to occur when the person is in a waking, a woken state. So anything that occurs while the person is falling asleep or while they're waking up are considered within the range of normal experience. So this is somebody who's been awake for several hours, they've been stimulated, and then boom, they hear something. But going to bed and waking up because those are kind of naturally altered states, that those would not be considered hallucinations. So hopefully a theme that you'll get from this class is to be culturally aware. So recognizing that each of us are seated in a specific culture. We are influenced by that culture, and that culture deems things normative and non-normative. And not everybody exists within that same culture. So just the recognition that when you are doing your assessment, being very mindful of the possibility of cultural influences that you may be unaware of, where something like a hallucination would be very normative. So for example, a part of a religious experience. So just really making sure that you are fully understanding the range of the like hallucinations and when they occur, in what contexts, so that you are getting really full, comprehensive, culturally sensitive information. So disorganized thinking, it's typically inferred from the individual's speech. So this person may switch from one topic to another very quickly, and it doesn't really make sense why they made a comment like this. So in terms of, you'll also see as a differential diagnosis with schizophrenia that ADHD is part of that, because as you know, individuals with ADHD can be a little bit scattered, or not necessarily scattered, like sometimes hard to follow in a line of thought because their brain's going so fast that they're making transitions that maybe they didn't express. So this, one of the distinguishing features between, so disorganized thinking or disorganized speech, that can be a symptom of ADHD. It's very different from schizophrenia because that ADHD is not complemented with or does not include hallucinations and delusions, which are really those more characterizing features of schizophrenia. So they may answer questions that feel very unrelated to what the conversation was discussing or focused on. So sometimes speech can be so disorganized that you can't even really understand the words that the individual is saying, or these words grammatically are very kind of very uncommon to be put together. So it's what we would consider, or what has been dubbed, kind of a word salad, where you could almost liken it to like Freud's concept of free association, but in a very disorganized form. So mildly disorganized speech is common in non-specific. This symptom must be severe enough to substantially impair effective communication. So again, like sometimes we have, brain farts or something like that. Or it may just be somebody with a comprehension issue, but in order to be considered disorganized thinking, it has to be substantially affecting in a negative way communication that can be understood. So the severity of the impairment may be difficult to evaluate if the person making the diagnosis comes from a different linguistic background. So again, this may be something where you have like a cultural liaison, just really making sure that you are bringing in whatever resources you have, because like it says here, these may be very normative ways of communicating in a different culture, but because you are not part of it, it can feel abnormal to you. So just really making sure that you're not, if there is any sort of confusion or anything that creates pause, go with that and be very vocal about what is creating pause, and collaborate, consult, use the resources that are available to you. So less severe disorganized thinking or speech may occur during prodromal. So this is when like the symptoms of schizophrenia just start to show up, and residual when the person is starting to recover, but they are still having symptoms. So just know that in the context or the timeline of schizophrenia, that these 2 points would be important to do some assessment around, to see, okay, when did these symptoms start to show up, what was it like? Like, did you have any difficulty communicating or expressing yourself? Did you find that people had difficulty understanding you? These would be some assessment questions. So then there is disorganized or abnormal motor behavior. So catatonia, I have a whole slide specific to all of the potential features or ways that catatonia can manifest or present itself. So this is grossly disorganized or abnormal motor behavior that can manifest itself in a variety of ways, ranging from a childlike silliness to unpredictable agitation. So it could be somebody who is maybe laughing at where there's no clear cues as to why that person, like what that person may find funny. This could also be a person who is just sitting, kind of not being engaged with, and all of a sudden they become very agitated, where maybe they throw something or they shout something. These would be considered disorganized or abnormal motor behavior. So problems may be noted in any form of goal-directed behavior leading to difficulties in performing activities of daily living. So this could be, so a goal-oriented behavior would be like brushing your teeth, brushing your hair, putting on your shoes. So where their motor skills are in a place that is difficult for them to complete the task. So catatonic behavior is marked by a decrease in reactivity in the environment. So these are, again, those kind of negative symptoms or presentations of catatonia. So this is a range from resistance to instructions. And again, I'll talk about this in a later slide, considered negativism, to maintaining a rigid, inappropriate, or bizarre posture. I don't know. I think what is the movie with Robin Williams, where he goes to the hospital? It's a really good movie. It's a sweet movie. But he goes and dresses up as like a clown to bring joy to people who are institutionalized or people who are in hospitals. And one of the scenes has a person sitting in a wheelchair with their hand just like straight above them, and they've been in that position for multiple hours. That would be the rigid posture that usually like kind of goes against gravity, and the person holds it and is in that position, non-responsive. So, if you were to try to stimulate their eyes or catch their gaze, their eyes wouldn't track with your finger. They wouldn't respond to any verbal cues or anything like that. So that's just in the media, one of the examples or kind of presentations of catatonia. And so bizarre posture to a complete lack of verbal or motor responses. This is considered mutism or in a stupor. They can also include purposeless or excessive motor activity. So these are the more like positive symptoms of catatonia. And it's these excessive motor activities without any sort of seemingly obvious reason as to why they would be moving in this way or talking in this way. So other features are repeated stereotyped movements, staring, grimacing, mutism, and echoing of speech. I will talk about all of these in a later slide. So even though catatonia has generally been associated with schizophrenia, these can be part of other mental health disorders as well. So just be aware that just because you're seeing either like the negative or positive symptoms of catatonia, that the diagnosis isn't automatically schizophrenia. So just keeping that in mind. So some of the negative symptoms. So two prominent negative symptoms of schizophrenia are diminished emotional expression and avolition. So diminished emotional expression is a reduction in the expression of emotions in the face, any sort of eye contact, intonation of speech, and movements of the hand, head, and face that would normally give some kind of like indication of engagement. It's again, these like very kind of culturally normative ways of engaging with another individual. So again, even as I said that, culturally normative to what I know. But I'm just thinking of other cultures where it is considered like very disrespectful to make eye contact with an elder, so just again, keeping that culturally sensitive, that culturally aware cap on at all times. So again, whatever is like normative in this individual's culture, if you are seeing things in terms of expression that do not go along with that, that may be an indicator of schizophrenia. And then avolition is a decrease in motivated self-initiated purposeful activities. So these might be things like that the individual, again, doesn't brush their teeth, doesn't brush their hair, doesn't tie their shoes, doesn't buckle their belt. So that's what that would be. Alogia is a diminished speech output. So an individual who is just maybe not, if they are in a like social interaction, they may be like off to the, maybe like a social setting, they may be off to the side. If they are in a like one-on-one conversation, you may have to ask lots and lots of questions to get any sort of engagement from the individual, if any. Anhedonia, this is one that is very common with depression. So this is a decreased ability to experience pleasure from positive stimuli, or a degradation in recollection of pleasurable experiences previously that the individuals had. And then asociality is a lack of interest in social interactions that may be associated with avolition, or it could be because this individual just doesn't have very many opportunities for social interactions. And again, that might be because this individual maybe doesn't seek them out. Maybe there's been they've been ostracized. So the opportunities just really aren't there. So again, these are all questions that you should ask when you are figuring out an appropriate diagnosis, and just honestly trying to get to understand the human more. So schizotypal, it's a personality disorder that it's placed in, or it's noted in the section on schizophrenia, but it's also considered a personality disorder. So we'll talk a little bit about this later on in the course. So this is a pervasive pattern of social and interpersonal deficits. So the person has a reduced capacity for close relationships. So again, you can kind of see how this could even potentially look like borderline personality disorder, cognitive or perceptual distortions. They're very eccentric in their behavior. So there's just a lot. There can be quite a bit of overlap in many of the criteria for different diagnoses. So this is just, I wanted to mention this here. So in terms of timeline or chronology, so this is usually starting in early adulthood, but in some cases, this can be apparent in childhood or adolescence. So any sort of personality disorders, you're going to see those present generally between the ages of 18 and 25, with a little bit of, give or take of range there. But with schizotypal, there's abnormalities in their beliefs, thinking, and perception that don't quite meet the criteria for a psychotic disorder. But again, we'll talk more in depth about schizotypal when we get to personality disorders. So psychotic disorder has two conditions that are defined by abnormalities, and these are delusions and catatonia. So again, I'll have a whole slide on catatonia in just a little bit, but the timelines of the diagnoses, or this, I guess the timelines of the symptoms, are really some of the differentiating factors within this grouping of diagnoses. So with schizophrenia, brief schizophrenia, schizophreniform schizophrenia, we'll talk about that in a little bit. But delusional disorder is characterized by at least 1 month of delusions, but no other psychotic symptoms. So a psychotic disorder is differentiated from a brief psychotic disorder, which lasts less than a month. Also, just keeping in mind some of these lifetime prevalences that have been established. And the majority of these diagnoses are quite rare. So 0.2% of individuals have been diagnosed with psychotic disorder. And again, the most frequent subtype, as I mentioned before, is persecutatory. So brief psychotic disorder, this is kind of, brief psychotic disorder, schizophreniform and schizophrenia are, these are diagnoses that you kind of want to keep, or symptoms that you want to keep your eye on. So with a brief psychotic disorder, the sudden onset of at least one of the following positive psychotic symptoms. So again, like we covered, delusions, hallucinations, disorganized speech, abnormal psychomotor behavior, or like a negative symptom like catatonia. It lasts more than 1 day, but it goes into remission in 1 month. So it's a sudden onset as a change from a non-psychotic state to a clearly psychotic state within 2 weeks. So in those, in that 1 month period, so it's without having an early symptom indicating the onset. So prodrome is an early symptom indicating the onset of a disease or an illness. So it's usually without that. So it's very spontaneous. There's really no, figuring out the etiology of it would be difficult. So again, in the US, so thinking, culturally specific here, brief psychotic disorder accounts for 9% of cases of first onset psychosis. So 9% of cases kind of move into some or other type of diagnosis. So in terms of onset, this may occur in adolescence or early adulthood, but it can range quite a bit. So but the average onset is in someone's mid-30s. So this is, again, when brain development has happened, and a screening question that you would start, again, with understanding or kind of being more choosy in your decision tree is, have you had any strange experiences lately? So then schizophreniform is, it is exactly like, the presentation is exactly like schizophrenia, but it lasts less than 6 months. So it's more than 1 month, because then that would be brief psychotic disorder, but it's less than 6 months because that would be schizophrenia. So the duration is, like I just said, the intermediate between brief psychotic disorder, which lasts more than 1 day and remits after a month, and schizophrenia, which lasts at least 6 months. So with this, a screening question, it's actually the exact same screening question as it is for schizophrenia, is, do you ever hear voices, believe people mean to harm you, or lose touch with reality? So then there is schizophrenia. So schizophrenia lasts at least 6 months, and it includes at least 1 month of active phase symptoms. So these are like active hallucinations, active delusions, active disorganized speech. And as it's noted here, the schizophrenia involves a range of different kind of dysfunctions, cognitive, behavioral, and emotional, but there's no single symptom. I think this is pathognomonic. Specifically, so the definition of that word is specifically characteristic or indicative of a particular disease or condition. So there's like not one thing that says like this is schizophrenia. It's a grouping of symptoms. So this is distinct. Schizophrenia is distinct from psychotic mood disorder because it requires a presence of delusions or hallucinations in the absence of mood episodes. So you're not manic, you're not depressed, so your mood is not necessarily affected. When an individual is experiencing schizophrenia, anxiety and phobias are very common. So that can make sense with the type of delusions that an individual could be experiencing. Some individuals with schizophrenia show social cognition deficits. So these are deficits in their ability to infer the intentions of other people. So again, autism spectrum disorder is one of the differential diagnoses for schizophrenia, because an individual with autism spectrum disorder may have difficulty inferring intentions of people, but they do not have delusions or hallucinations. So, just kind of giving you some symptoms and some things to keep in mind as we are becoming more familiar with more diagnoses within the DSM, just hopefully giving you kind of like a frame of reference here. So they may attend to or then interpret irrelevant events or stimuli as meaningful, so that you can see the like referential delusion a little bit, perhaps leading to the generation of explanatory delusions. Some individuals with psychosis may lack insight or awareness of their disorder. And that insight includes unawareness of the symptoms of schizophrenia. So one of the, so unawareness of the illness is typically a symptom of schizophrenia itself rather than a coping strategy. So that would be something that would be indicative of schizophrenia, of the fact that this individual really may not be aware of their symptoms. They may not really necessarily feel distress about that because they're just not aware that they're experiencing symptoms of schizophrenia. So some more information about schizophrenia. So again, like I mentioned at the kind of top of this lecture, the vast majority of persons with schizophrenia are not aggressive and are more frequently victimized than are individuals in the general population. So lifetime prevalence is, again, less than 1%, 0.3 to 0.7%. Some of the psychotic features. So again, the onset of like late teens to mid 30s is pretty common in many of the so as we've moved through kind of the neurodevelopmental, now the groupings of diagnoses that we're in, that early adulthood to mid 30s is a pretty typical onset for any sort of symptomology. And any onset of psychotic features of schizophrenia in adolescents are rare. So again, like if you're seeing this, be very critical in terms of just accepting that kind of diagnosis. But just like as you are assessing, recognize that this presentation may be schizophrenia, but like, so if, for example, you have an adolescent in your office, but that there may be a better explanation that fits rather than schizophrenia. So approximately 5 to 6% of individuals with schizophrenia die by suicide, and about 20% attempt suicide on one or more occasions. So these are many times led by command hallucinations. So these are hallucinations so auditory hallucinations that an individual is experiencing, saying to do something that person may not necessarily want to do. So this is where I think some of the this stereotype of individuals with schizophrenia are inherently dangerous, because I think that especially in media, command hallucinations have kind of been sensationalized, and it's as if every single person with who has been diagnosed with schizophrenia or not, who is experiencing symptoms of schizophrenia, maybe they're not diagnosed, is experiencing command hallucinations, and that's just really not the case. That this is a person who is being commanded to like blow up a building or, start killing people. And that's just really not the case. So many times media just really does an injustice. I would say nearly all the time does injustice to any people with any sort of mental health diagnoses. Rates of comorbidity with substance-related disorders are high. So as I mentioned, I think in my first or second week's lecture of, just trying to self-medicate. So maybe this person doesn't have the resources to get assessed, or maybe the medication that they use, they're not able to have that on a regular basis. So what do? We take substances to counteract the symptoms. So with something like schizophrenia, depending upon the type of symptoms that they're having. So if they're positive symptoms, individuals tend to take depressants to just try to minimize some of the positive symptoms that they're experiencing. And if they are experiencing negative symptoms, they tend to take stimulants. So again, they're just trying to kind of be at a baseline, and substances can be of aid to them in that. So as you can see, the screening question for schizophrenia is the same as schizophreniform. Do you ever hear voices, believe people mean to harm you, or lose touch with reality? So schizoaffective, this is a mood episode, and the active phase symptoms of schizophrenia, they occur together, and were preceded or are followed by at least 2 weeks of delusions or hallucinations without prominent mood symptoms. So this is the kind of introduction of a mood disorder or mood symptoms as well. So their occupational functioning is frequently impaired, but that's not a defining criteria, which is one of the differentiating factors with schizophrenia, because that does create, or schizophrenia does affect or does create some impairment in occupational functioning. They may have, individuals with schizoaffective disorder may have restricted social contact and difficulties with self-care, but the negative symptoms may be less severe or less persistent than seen in schizophrenia. So again, just some of these kind of comparing and contrasting language as you are doing some differential diagnosis. Schizoaffective disorder appears to be about 1/3 as common as schizophrenia. So lifetime prevalence is 0.3%. So again, these are pretty rare diagnoses that we're covering this week. Typical age of onset is early adulthood, although onset can occur anywhere from adolescence to late in life. So sometimes the ranges are very big, so they may not be as helpful, but just know that the age of onset is early adulthood. So this is, again, 18 to 25. So criterion C is symptoms that meet criteria for a major mood episode are present for the majority of the total duration of the active and residual portions of the illness. So that's criterion C, is designed to separate schizoaffective disorder from schizophrenia. And criterion B, which is delusions or hallucinations for 2 or more weeks in the absence of a major mood episode during the lifetime duration of the illness. So criterion C and criterion B are designed to distinguish schizoaffective disorder. So criterion C is meant to separate schizoaffective from schizophrenia, and criterion B is designed to distinguish schizoaffective from a depressive or bipolar disorder with psychotic features. So those are meant to help you in going down that decision tree and making the appropriate diagnosis. So a screening question here, you can see it's almost exactly the same as schizoaffective and schizophreniform, but with one additional question. So do you ever hear voices, believe people mean to harm you, or lose touch with reality? That's the one we've heard before, but the additional piece of schizoaffective is, do you ever have mood swings? So then we talked about, or you read about, substance and medication-induced psychotic disorder. So again, this is when we're doing differential diagnosis, you very specifically look at the possibility of substance use being an explanation here, but this is where the medication or substance-induced psychotic is prominent when there is substance use. So the symptoms arise during or soon after exposure to a medication or a substance, or like, so after intoxication or withdrawal, they can persist for weeks. But the difference here, so again, is that the primary psychotic disorders may precede the onset of the substance use or the medication use and may occur during times of sustained abstinence. So you would know that it would just be non-substance or medication induced psychotic disorder if the timeline of substance use doesn't align with the symptoms. So if this person has been, for example, they've abstained from whatever substance or medication for 5 years and they're experiencing psychotic symptoms, then you know it's not substance or medication induced. So once initiated, the psychotic symptoms may continue as long as that substance or medication use continues. So if the individual, this is not brief necessarily, if that individual uses the substance or is on that medication for 20 years, it would be logical to expect some kind of psychotic symptom during those 20 years. So factors that suggest that the psychotic symptoms are better accounted for by a primary psychotic disorder include persistence of the symptoms for a substantial period of time after the end of substance intoxication and withdrawal, or after succession of the medication use. And another thing, so again, if the timeline of use and the symptoms kind of just don't really make sense, it's probably not, the explanation probably isn't substance or medication induced. Another factor is a history of prior recurrent primary psychotic disorders. So prior to that person maybe using any sort of substance or medication, if they've had some psychotic symptoms, that can be an indicator that that is the primary diagnosis. So a screening question here is, do you have strange experiences when you are under the influence of drugs or alcohol? You could probably even, well, drugs could be medication, but I would be clear about that because I think many times when we hear the term drug, we think illicit. So don't hesitate to add in medication. So psychotic disorder due to another medical condition. So when you're determining whether the disturbance is attributable to another medical condition, the presence of the medical condition must be identified and considered to be the etiology or the foundation, the reason of the psychosis through a physiological mechanism. So something like brain function. So you would need some sort of scan, you would need additional assessment that would be provided by a medical professional outside of the mental health field. So even though there are no perfect guidelines for determining whether the relationship between this disturbance and the medical condition is etiological, there are a couple of considerations. So one is the presence of again, the temporal or the time-specific association between the onset, exacerbation, or remission of the medical condition and the psychotic disturbance. So if, for example, this individual has a diagnosis of cancer and there was some psychotic symptoms during the onset, maybe the cancer got worse, or during remission, but then once the cancer was cured or in remission, there was no longer any sort of psychotic disturbances, that would be something to consider. So a second consideration is the presence of features that are atypical to the psychotic disorder. So maybe that the age of onset just is very atypical, or they're having more like rare hallucinations. That would be something to consider. So lifetime prevalence is 0.21 to 0.54%. So again, rare. And psychotic disorder due to another medical condition is more prominent in older populations. So a screening question here is, have you had any strange experiences when you've been sick or when you're ill? All right, so catatonia. So this is, again, I think kind of stereotypically believed to be negative symptoms, but we'll go over all 12 of the kind of possible presentations of catatonia. So there is stupor, which is no psychomotor activity, not actively relating to the environment. So this is a person who is just kind of existing in the space, but not engaging in any way. catalepsy, which is a passive induction of a posture held against gravity. So this is where maybe somebody else puts the person in a position and they just stay there. Waxy flexibility is probably one of the most common presentations of catatonia. So this is slight even resistance to positioning by an examiner, where they're just, they're resisting being put in a position. Mutism, no or very little verbal response. Negativism is opposition or no response to instructions or external stimuli. So mutism is no response to a cue. Negativism is not responding to or doing something opposite of any sort of external cue. Posturing, that spontaneous and active maintenance of a posture against gravity. So likely for anybody who got my reference for Robin Williams movie, that's what that was. Mannerism is odd, circumstantial caricature of normal actions. So just, very exaggerated, or more of an exaggerated expression of that. Stereotypy is repetitive, abnormal, frequent, non-goal directed movements. So this could be, somebody like patting their head, stomping, just things that, again, that don't necessarily seem to have a purpose. Agitation that is not influenced by external stimuli. So again, this is agitation that in context, doesn't necessarily seem like it was provoked in any way. Grimacing, echolalia, so that is mimicking another person's speech, and echopraxia is mimicking another person's movement. So these are those kind of 12 manifestations or presentations of catatonia. So this is typically, catatonia is typically diagnosed in inpatient settings and occurs in up to 35% of individuals who have been diagnosed with schizophrenia, or I guess who have schizophrenia. But just to be clear that the majority of catatonia cases involve individuals with depressive or bipolar disorders. So again, it's not exclusive in any way to schizophrenia. And then we read a little bit on a family-focused approach to serious mental illness, empirically supported interventions. And really, it was a pretty short read, but largely the message, I think, particularly for us MFTs, is that families can be largely excluded from treatment. And it's really important. So we think of like family-focused approach with like substance use disorder, for example, and like that makes sense, but why is it that families tend to not be as integral of a part when there is a diagnosis of a serious mental illness? So just, this is a lane that we can absolutely occupy and a lane that we can advocate for in terms of just including families in the treatment. And just another point is that when we think of family, we tend to think of parents, or if an individual is older, maybe their children or their partner or something like that. So just furthering the conceptualization or the inclusion of family, thinking beyond parents. So for example, there's lots of literature that show that siblings are largely excluded from treatment. So just advocating for the inclusion of individuals that are not parents or partners to be a part of the treatment.